So I am going to kind of line up Brooke how I think she's going to, where it's all going to line up. So I'm going to bring this up just a little bit. And then, let's see where this looks. And the reason is I have Brooke kind of like, she's relaxed, but she's not tense. Like we're looking at OML, right? Okay. And I'm not going to line this up quite yet because I am going to make her move a little bit. So I'm going to just tuck here. And then we're going to go OML is perpendicular with the IR. Actually, that looks really good. I'm going to tuck just a little bit. Okay, good. And I'm going to move this board down just a bit. Okay, so I think it's important to just do that because it's a small little tweak at the end, because so often, like when I'm the patient and I'm testing students, they're like moving this all around, and it's like, just get the major stuff figured out and then the small little details will come. Okay, so sorry, a little bit more down. Okay. For collimation here, side to side, we want to make sure that we see both sides of the mandible. And then up to down, you can see like I'm missing the synthesis. So we'll open that up to make sure that we've got that. And then the marker will go on the side here. Right side. Obviously you would shield your patient. Questions on AP modified town. The modification is central ray. You can relax. Lengthwise is a straight PA. So I'm gonna have you turn around and face the IR. For this one, I would like you to put it in crosswise. So I just heard the collimators open up for PBL. We will lower this. And I'm going to get about where I think she will be. Where is our central ray exiting this one? A Cantillon. What line are we lining up? OML. Very good. So I am going to, before I get her too flustered, right, or too like trying to hold a position for too long, I get to about where I think she needs to be. I'll say, go ahead and place your nose and forehead on the board. And I'm just gonna move your hair to the side a little bit. So that way we can see. I'm gonna line up. I'm gonna bring your chin up. Keep going. That looks good right there. Okay. And then I need to go down a little bit. The board's gonna move down. Collimate side to side. We want to make sure that we can see both sides of the mandible. And then top to bottom can be fairly close, but remember that we want to include the TMJs because that's part of that bone. And then we would mark up in the corner here. Straight PA, OML, exit a Cantillon. Questions on that? Okay. If, when you do your first AP town, if the fracture is in the body of the mandible, for this projection, you will then, instead of centering at a Cantillon, you will have the patient lift their chin and you will center at exit lips, okay? If there's a fracture on the body, and that just elongates that bone so that we can see it better. Questions on that? Okay. Right?
The foundation is on.
It's okay. Okay, axial lateral obliques, horizontal, IR. So what I consider the true lateral is interpupillary, perp, mid-sag, parallel, and IOML parallel with the transverse axis of the IR, okay? So we are not in a true lateral for this picture, got it? We are in interpupillary, mid-sag, we will bring the chin up and jet it out so that the bottom of the jawline is parallel with the transverse axis of the IR or parallel with the floor. Got it? The tube will need to go down. You'll go to 30 degrees, which is 120, and then you'll just kick it back about 5 degrees. You know, when you're in your clinical sites, that'll actually show you exactly 25 degrees. So once again, I am going to get it about where I think the anatomy will be so that I'm not making her move a ton when I get her all set up. Central ray for this is the upside gonian. The lab notes does say area of interest because this is a long bone. And then I'll talk a little bit about just what it looks like and how much we rotate. For the competency, we will rotate 15 degrees, which is what the general survey is. Got it? But you will need to be able to know the rest of them. And I'm just gonna, real quick, this is kind of off the cuff here, but like come forward a little bit. So here is upside gonian. Let's say I'm close to that central ray there. If the area of interest is the symphysis, look at how much light we have here. It doesn't really make sense, does it? So really we would, like in the real world, we're probably gonna center at gonian all the time. The other thing to think about is just like your AECs and how much, if you're centering at symphysis, you're probably gonna turn off an AEC here just due to exposure. Make sense? Okay, so for these, you're gonna do both sides and then have your patient straddle the pole or, you know, get nice up and close. I want you nice and close, nice and tall. And then if you bring your chin out, that looks good. So that's mid-sag parallel, interpupillary looks perpendicular. And then I'm gonna have you lift your chin and just jet it out as much as you can. That takes the gonian away from the C-spine. And then, oh shoot, sorry, scratch that forward. Don't know what I'm doing. Okay, so from here, it's a mid-sagittal rotation into the board. Okay, so I'm gonna have you take your nose and just bring it to, there you go, right there. And that's a general survey. Now I'm gonna have you bring it back out. And I want you to hold there for just a little bit. So when we think about physics, this, let's say that the area of interest is the symphysis, what we want to look at. This right here is an angle. So 45 degrees is what we internally rotate. So rotate your nose in or mid-sag in and keep going, keep going, keep going. So now look, symphysis is the area we want to look at. It's closest to the IR. Less magnification, more image detail. That's what those numbers are for, okay? So now you can go back, you can relax actually. Gonian, it's just right there, so we don't have to rotate. Body is 30 degrees, and then the general survey is just 15. But it all has to do with a little bit of physics, right? We wanna try and elongate that body part. We wanna try and get it as close to the IR as we can for more image detail, blah, 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 blah. Make sense? I'm going to put you back up here and just talk about collimation. Collimation for this. You don't want to collimate in too much here because we do rotate you in, this backside gonian comes back. So make sure that you leave it out. The other thing is with this sharp angle up, see how we can see her shadow here? And your shoulders here. I'm gonna have you just bring your shoulder up. If you have a big bulky person, this won't be able to penetrate, okay? So we wanna be able to see this shadow, and I'm just gonna take your arm. A lot of the times what I'll have somebody, like a patient, do is just grab down below or even do a sandbag of some sort. And then that helps so that you can differentiate between, or try and get that shoulder out of the way. You can relax. If you still can't get the shoulder out of the way, this is a 25-degree tube tilt, and you need to have some sort of combination of 25 degrees. We're all about angles, right? So instead of 25 degrees here, you could take off 5 degrees, 20 degrees here, and then what we would do is we would tilt the head 5 degrees. Got it? Or 10 degrees here, 15 degrees head tilt. if you've ever done one of these out in the field, what was that? Oh, sorry, I thought you said something. If you've ever done one out in the field, they might do a perpendicular beam, and they call it the lazy lateral. So I just get my patient, let's have you up nice and tall, and come away from the board a little bit, and I just want you to tilt the top of your head to the IR. Keep going, sorry. And then, but it's called the lazy lateral because it's much easier to get that shoulder out of the way than the big cephalotube tilt. You can relax. Does that make sense? So this is about 25 degrees with a perpendicular IR, or beam. Questions? Okay, let's have you break